alcohol consumption. India is a land of youth, a land of energy, vitality, and ambition. However, there's an increase in the prevalence of lifestyle diseases, that is, diabetes and hypertension. Risk factors responsible for these conditions are stress, sedentary lifestyle, obesity, smoking, and excess alcohol consumption. These lifestyle conditions are also affecting their vitality and energy, and in turn leading to one prominently occurring condition of erectile dysfunction. 52% of Indian males aged 40 to 70 years are suffering from ED, leading to decrease in their confidence level. Healthy sexual life helps in maintaining the feeling of youth and overall well-being in sexual disorder like ED. Zydus Fortisa, a division of Zydus Healthcare Limited, presents Men's Sexual Health Portfolio, which comprises of Penegra, Zydalis, You Desire, Sustanon. Penegra is the #1 prescribed brand of sildenafil with half-life of 4 hours. Duration of action up to 8 hours. Penegra can be recommended for moderate to severe ED patient, long-standing diabetes patient, as efficacy is independent of age, duration of ED or diabetes. Zydalis is a brand of tadalafil that comes as mouth-dissolving mint-flavored tablet. Zydalis has longer duration of action up to 36 hours with no dietary restrictions. Recommended for the treatment of younger 40+ mild to moderate ED patients. Provides spontaneity and better patient compliance. Sustanon is a brand of testosterone used in the management of ED with hypogonadism. Sustanon shows considerable increase in duration and maximum level of penile rigidity. Improved libido in hypogonadal men. You Desire is the brand of Sildenafil, which gives assurance of efficacy and safety. Help your ED patients to feel youthful and maintain overall well-being with the benefits of Penegra, Zydalis, Sustanon, and You Desire. Of youth, a land of energy, vitality, and ambition. However, there's an increase in the prevalence of lifestyle diseases, that is, diabetes and hypertension. Risk factors responsible for these conditions are stress, sedentary lifestyle, obesity, smoking, and excess alcohol consumption. These lifestyle conditions are also affecting their vitality and energy, and in turn leading to one prominently occurring condition of Erectile dysfunction. 52% of Indian males aged 40 to 70 years are suffering from ED, leading to decrease in their confidence level. Healthy sexual life helps in maintaining the feeling of youth and overall well-being in sexual disorder like ED. Zydus Fortisa, a division of Zydus Healthcare Limited, presents Men's Sexual Health Portfolio, which comprises of Penegra, Zydalis, You Desire, Sustanon. Penegra is the #1 prescribed brand of sildenafil with half-life of 4 hours, duration of action up to 8 hours. Penegra can be recommended for moderate to severe ED patient, long-standing diabetes patient, as efficacy is independent of age, duration of ED or diabetes. Zydalis is a brand of tadalafil that comes as mouth-dissolving mint-flavored tablet. Zydalis has longer duration of action up to 36 hours with no dietary restrictions. Recommended for the treatment of younger 40+ mild to moderate ED patients. Provides spontaneity and better patient compliance. Sustanon is a brand of testosterone used in the management of ED with hypogonadism. Sustanon shows considerable increase in duration and maximum level of penile rigidity. Improved libido in hypogonadal men. You Desire is the brand of Udenafil, which gives assurance of efficacy and safety. Help your ED patients to feel youthful and maintain overall well-being with the benefits of Penegra, Zydalis, Sustanon, and You Desire.
Respected doctors, my name is Dr. Aishwarya and I welcome you all for today's webinar in sexual health. It gives me immense pleasure to welcome our expert here, Dr. Gandharb Ray sir, ex-professor medicine and sexologist from SCB Medical College, Odisha. Sir's topic for today is sexual health in diabetic patients. I request Sir now to take over the session and request all our viewers to post your comments or your questions in the comment box below this video. Thank you, sir.
Good evening to all the esteemed participants to this webinar organized by Zydus Fortisa. I give my hardcore thanks to Zydus Fortisa for arranging this webinar, specifically to Dr. Aishwarya and other supportive staffs. So we'll now start our topic, that is sexual dysfunction in diabetes. The sexual function, is a common problem in patients of diabetes, but most of the times it is neglected because most of the people, they hide their sexual problem. They do not divulge their problem freely to the doctors, and that's why it remains suppressed. And unless it is very critical, they do not come forward. Particularly elderly people, they do not want to express these things. And in younger people, they come quickly because this is the most important problem for them. But in elderly people, they usually hide it for a longer time, then they express ultimately. The sexual problem in diabetes can be divided into three parts. Most important is the erectile dysfunction, most common problem. Second is ejaculatory dysfunction. Third is female sexual dysfunction. Now let us first see the erectile dysfunction, which is the most important part of the topic. We will talk on the agenda: introduction, epidemiology, pathophysiology of ED, clinical features and investigations, treatment, conclusion, and take-home message. Diabetes has been associated with sexual dysfunction both in men and women. Diabetes is a risk factor for sexual dysfunction in men. 3 times increased risk of ED is seen in diabetic patients than non-diabetics. Among the men with ED, those with diabetes are likely to have experienced the problem for the last 10 to 15 years before they present. The International Diabetic Federation, or IDF, estimates globally there are 425 million people suffering from diabetes, out of which 50% have erectile dysfunction. Age is a strong determinant of occurrence of erectile dysfunction, and epidemiological studies indicate that there is a stronger relation between ED and advancing age. While men aged 50 to 59 years have 3.6 times higher risk of developing ED as compared to people with 18 to 29 years. And the risk is even higher, 6 to 7 times more in patients with older patients of 70 years. Age-related hormonal, metabolic, and inflammatory, as well as increased prevalence of other risk factors for ED in older population may be responsible for increased prevalence. Let us discuss about what are the causes or etiology of erectile dysfunction. It may be several causes. Most important is psychological disorder in the form of anxiety, psychological trauma, depression, psychosis, and misconception. Vascular disorders like peripheral vascular disease, hypertension, venous leaks, or venous incompetence. Neurological disorders in the form of stroke, peripheral neuropathies, multiple sclerosis, spinal and pelvic trauma. Endocrine metabolic disorders. Diabetes is the most important disease we are discussing. Hypogonadism, thyroid dysfunction, hypopituitarism, hyperprolactinemia, hyperlipidemia, liver disease, and renal disease, and other miscellaneous causes like smoking, drug abuse, and alcohol use, and some other things. I cannot hear it, cannot see. Then coming to the pathophysiology. What is the physiological, pathophysiological changes, derangements which occur due to these etiological causes? Type 2 diabetes is associated with raised blood sugar and insulin resistance, and there is also associated hyperlipidemia, hypertension, obesity, and a sedentary lifestyle. All these factors lead to vasculopathy, neuropathy, hypogonadism, and local factors. Most important thing is vasculopathy. It may be a macrovascular disease, microvascular disease, endothelial dysfunction. Neuropathy may be diabetic autonomic neuropathy or peripheral neuropathy. The hypogonadism may be associated in patients of diabetes like decreased level of sex hormone binding globulin or SHBG, decrease in free testosterone and total testosterone levels, and local factors in the sexual organs in the form of Peyronie's disease, balanitis, phimosis, and fibrosis. When there is all these derangements, there is decrease in the production of nitric oxide, which leads to decreased vascular cavernosal smooth muscle relaxant. It is a relaxing factor, endothelial relaxing factor, as a result of which When there is decreased production of nitric oxide, the relaxation of the cavernosal smooth muscle do not occur, blood do not engulf in the sinusoids, as a result of which there is no erection. Associated with that, most important thing is the psychological factors in the form of depression, anxiety, and the libido. They can enhance this condition. ED associated with the diabetic control complications and medications. Liu et al. Conducted a study in 792 men, of whom 83% had some degree of ED and 43 had serious ED. The studies and the authors also performed subgroup analysis to investigate the association between age and ED. The study showed that even after controlling the age, duration of the disease, there was an association between glycated hemoglobin levels and ED. In patients aged less than 60 years, glycated hemoglobin, age and duration of diabetes were independent predictors of ED. However, in patients more than 60 years, only age and duration of diabetes was predictor of ED. In patients with diabetes, the severity of ED has been linked to a number of circulating endothelial microparticles. The same slide continued. The medication that patients are receiving for the treatment of diabetes and their complication may influence also the erectile dysfunction. In particular, ED has been associated with the use of beta blockers, thiazide diuretics, metformin, antidepressants, statins, fibrates, drugs used for neuropathic pain like pregabalin, gabapentin, and opiates. In patients with other drugs may also have beneficial. Some drugs may be beneficial in patients with hypertension and diabetes. If you are using valsartan, a ARB, then it may have some beneficial effect. It can decrease the incidence of ED from 65 to 45%. Then coming to the clinical features, what we will see in the patient, the key features in the history, onset usually gradual and progressive. Earliest features are inability to sustain erection long enough to satisfy the intercourse. Initial intermittent erectile failure. Sudden onset usually indicates a psychological cause. Loss of libido consistent with hypogonadism, but not a reliable symptom. Men with ED often understate their sex drive for a variety of reasons. Physical examination may show features of hypogonadism, protuberant abdomen, manual dexterity, external genitalia. There may be presence of phimosis or fibrosis. Testicular volume might be small. Investigation are serum testosterone, pre-testosterone, or total testosterone, then serum LH and FSH, assessment of the cardiovascular status, ECG, serum lipids, HbA1c, blood sugar levels, electrolytes, and penile ductal. Let us come to the most important part. We have now discussed about the epidemiology, the etiology, the pathophysiology, and the clinical features of ED. Now we'll discuss what is the treatment. How will we manage these patients when a patient of diabetes having ED and he presents to the physician, then what are the steps he has to take? Most important is physical activity. Beneficial effect of prevention. It is beneficial for prevention and or improvement of ED. Weight loss. Obese patients have increased incidence of ED, and it is probably 70 to 96% higher in comparison to the normal weight patients. Dietary factors. Esposito et al. In a study of 65 men with metabolic syndrome found that 35 of them with the intervention diet and 30 control patients with the normal diet found that the IAEF score, that is the International Index Erectile Function Score, improved in 22, increased up to 22. The IIEF score increased up to 22 in 13 men in the intervention group, but in 2 men in the control group. That means they have taken 35 intervention group, 30 the control group. In the intervention group, there was significant improvement in the erectile function score. It was up to 22 in 13 men, whereas in the normal diet group, only 2 people got improvement. This indicates that dietary restrictions is very important for the improvement of ED. smoking. When there is smoking has a adverse effect on ED, so smoking should be stopped. Alcohol consumption in a moderate amount is protective, but increased amount of alcohol may have deleterious effect in the ED. Glycemic control. Liu et al. Also concluded that in 83% of patients with the ED and 43% with severe ED, better glycemic control probably would reduce the prevalence of ED and its severity among the young men with type 2 diabetes, while age is the major determinant for ED in the high-risk groups. Then coming to the treatment continued. What are the treatment options we have for ED? Most important is pharmacologic treatment. It should be offered as a first-line therapy to men with diabetes and erectile dysfunction, and other treatment options should be reserved for those who are not responding to oral therapy. Next line of treatment is intracavernosal injection therapy. Third is the transurethral alprostadil medicated urethral system, that is transurethral insertion of alprostadil, that is known as DUSE, and a topical alprostadil can also be applied on the around the urethra. Then next form of therapy is vacuum therapy, and finally surgery. The pharmacologic treatment is most important. It is usually given in a wide number of patients having ED. So you see, this is the non-erect penis and this is the erectile penis, where there is engorgement of the corpora cavernosa and there is erection. So in the corpora cavernosa, when there is stimulation, nitric oxide is released. This nitric oxide stimulates the guanyl cyclase enzyme, which converts GTP to cyclic GMP, which is the most important chemical. That is the second messenger. That stimulates. So the cyclic GMP, that usually decreases the calcium in the smooth muscles of the corpus cavernosum, as a result of which there is relaxation, engorgement with blood, and leading to erection formation. And this second messenger cyclic GMP is degraded by a enzyme known as phosphodiesterase 5. This enzyme degrades cyclic GMP so that its action is not sustained. So what is happening? We are having most important group of medicines, the phosphodiesterase 5 inhibitors like sildenafil, tadalafil, vardenafil, and avanafil. These fields are the 5 phosphodiesterase inhibitor 5. They inhibit the enzyme phosphodiesterase 5, as a result of which the level of cyclic GMP increased. When there is increased level of cyclic GMP, there is sustained erection. Then on the other side, we can see there is alprostadil. Alprostadil is a prostaglandin E1. This substance stimulates the PG1 receptors on the corpus cavernosum, as a result of which there is stimulation of adenyl cyclase. The adenyl cyclase enzyme breaks down the ATP to cyclic AMP. Cyclic AMP is also another second messenger which causes decrease in the calcium in the smooth muscles of the corpus cavernosum, leading to erection. Let us discuss more about the phosphodiesterase 5 inhibitors. The phosphodiesterase enzyme is found in the smooth muscles, platelets, and the corpus cavernosum. During tumescence, there is increase in the intracellular concentration of nitric oxide, which produces smooth muscle relaxation through the second messenger cyclic GMP or cyclic AMP, leading to, and this second messenger is broken down by phosphodiesterase 5. Hence, phosphodiesterase 5 inhibitors can enhance erection under the conditions of sexual stimulation. So we are having 5-5 inhibitors: sildenafil, vardenafil, tadalafil, avanafil. They are having different durations of action. Sildenafil is the first member of the group. It has already been introduced into the market for the last, I think, 15 to 20 years. It has been approved by FDA. This is having different strengths like 25 milligram, 50 milligram, 100 milligram. Onset of action is quick, 30 minutes, and its duration of action is nearly 12 hours, 10 to 12 hours. Vardenafil, another developed molecule of the series. It has 5 milligram, 10 milligram, 20 milligram. Onset of action is also quick, but duration of action little less than 10 hours. Tadalafil, it's a 10 milligram, 20 milligram available, but onset of action is late, but sustained action 36 hours. Avanafil available in 50, 100, and 200 milligram, but its half-life is 3 hours, and the duration of action is less than 6 hours. So the most important is the sildenafil. Next comes vardenafil. Next tadalafil. These are all available in the market. So this is the study of sildenafil in the treatment of erectile dysfunction in male diabetics. To describe the eligibility, consumption, efficacy, and patient satisfaction when treating men with sildenafil, the research design, it was seen that large number of people were recruited in the study. This is an old study, 2002, but this study shows that when the people were taken for this study, many people did not want because there was a lot of hue and cry about the bad effects of this drug. But ultimately, few people, 33 people, they completed the study, and there was a very significant improvement with this medicine. This shows the erectile function domain score in 33 patients who completed the study for a full period of time of 3 weeks. Erectile function score increased from, in the first visit, 9 to 18. The organism function score increased from 6 to 7. Then most importantly, then the sexual desire score that increased from 6.8 to 7. Overall satisfaction score increased from 4.2 to 6.8. The erectile function score that improved from 30 to 47. So in conclusion, there was a significant improvement in the 33 patients, and those who continued the medicine, they continued it. So this is a very good medicine. This should be prescribed in patients with ED. Thank you. Next. This is a vardenafil study in 2003. This is another molecule, and it was given in a quite good number of patients, 10 to 20 milligram available. And the vardenafil satisfactorily improved the erectile function and was generally well tolerated. This drug is also equally potent, and what's its direction of action is a little less. Intracavernosal, next comes about this. Then tadalafil is also available, and this drug is also available by Zydox Ortiza. Tadalafil is a good medicine, but its action is a little delayed, and a long duration of action is there. That is also very important. This is having adverse effects are minimal. So we can use sildenafil as the first line. We can use vardenafil. We can use also tadalafil. Then if the patient is failing with this phosphatidylsterase inhibitors, then we can go for other modality of treatment. Intracavernosal injection therapy, the particular substance which I will tell you later on just now, that is given into the corpus cavernosum, and you get the result. Intracavernosal injection therapy, usually the technique is intracavernosal therapy with the phentolamine, was started in 1983, but there are some adverse effects as a result which it was changed. Nowadays, alprostadil, which is a prostaglandin E1, is supplied in self-injection pen device, which is easy to use. Since 1983, the ICI or intracavernosal injection has become a staple therapeutic option with high success rates. Then its efficacy rate is approximately 94%, and the dropout rates are there, but most of them occurring in 2 to 3 months. But those who continue, they continue it for a long period of time. The complications with intracavernosa alprostadil is penile pain, prolonged erection, priapism, and fibrosis. And there is also combination of drugs like alprostadil plus papaverine or alprostadil plus the phentolamine. But if they are given, the success rate is 90%. So let us see how this injection is given. Transurethral alprostadil is given in a system known as medicated urethral system of erection or MUSE. This is another modality. The previous modality was injection, but this is a transurethral alprostadil. This is known as MUSE. This is given in the following manner. Transurethral alprostadil is a medicated urethral system for erection. This is given for a single use. The MUSE is administered by introducing the applicator system into the urethra after urination. The pellet containing the alprostadil is delivered by depressing the applicator button. The active ingredient MUSE is chemically identical to the natural icosanoid or prostaglandin E1. Then the MUSE goes to the urethra. It is available in 125 microgram, 250 microgram, and 500 microgram. The MUSE should be administered as needed to achieve the erection. The onset of effect is 10 to 15 minutes after administration. The duration of effect is approximately 30 to 60 minutes. Then fourth modality of treatment. First is our 5-diasteroid inhibitor. Second is the intracavernosal injection of alprostadil. Third is the MUSE, that is the intraurethral injection of the administration of this alprostadil pellet. And fourth is the vacuum therapy. Vacuum device has become widely available since 1970s. It consists of a translucent tube which is placed over the penis and is attached to the vacuum pump. The air is pumped out of the tube and a negative pressure draws the blood into the erectile tissue, producing tumescence. A constriction band is slipped to the root of the penis to cause obstruction of the blood going back, leaking back. As a result, there is erection. Then vacuum therapy started like this. It was reported that vacuum constriction therapy is achieved. It causes achievement of satisfactory response in 70% of diabetic men. Son et al. Reported that the combined use of sildenafil and vacuum constriction device for 3 months significantly enhanced erectile function, and it is well tolerated by diabetic patients. And the dose of sildenafil with vacuum constriction device is 100 milligram alone. Then comes the problems with vacuum constriction device includes pain due to constriction, lack of spontaneity, decrease in the quality of orgasm, and ejaculatory dysfunction. In addition, up to 30% of patients, there may be inadequate rigidity, penile pain, failure to ejaculate. So there are some adverse effects, but when the other methods like your 5-diasteroid inhibitors or the alprostadil fails, you can go for vacuum therapy. Then the last is surgery. In spite of the recent advances in the treatment of ED, some men will not be able to improve their conditions. So they can be subjected to surgery, but it has a limited role. The surgical option includes insertion of a penile prosthesis, corrective for surgery. You can also correct the Peyronie disease if it is present due to injection of corporal fibrosis. When the pharmacology fails, surgery can be adhered to. Penile implants provide a predictable and reliable erection and have a highest satisfaction rate among both patients and their partners of all the available treatments for waning erection. So now we have discussed the various devices that are required for improving the erectile dysfunction in patients with diabetes. Now we'll go to the second abnormality, that is ejaculatory dysfunction. This is also important. The ejaculatory dysfunction defined as the expulsion of the seminal fluid from the urethra to the meatus. The ejaculatory dysfunction is an important disorder from the viewpoint of male infertility. This may lead to infertility. Ejaculatory dysfunction is a complex pathological condition compared to ED. So if you see about the nerves, peripheral nerves, the nerves, they arise from the second lobar spinal cord. They go to the sacral segment S and 2. From that, efferent nerves goes to the sex organs, and from there also afferent nerves comes and they enter the spinal segment, the lumbar spinal segment. So what happens? The ejaculatory dysfunction, there is maybe either lack of ejaculation, known as retrograde ejaculation, or there may be premature ejaculation. Successful antegrade ejaculation requires coordination of three things. There is emission of the seminal fluid, bladder neck closure, and contraction of the muscles of the pelvis. If these three things, first thing is emission from the seminal vesicle, second is blockage of the neck of the bladder, third is bladder neck must close, third is contraction of the muscles. This will lead to ejaculation. In diabetes, due to neuronal disruption, there is these things do not correlate. When there is emission, there may not be closure of the neck of the bladder, as a result of which there occurs retrograde ejaculation. Sometimes there may not be ejaculation at all and the patient is dissatisfied. Coming to the pharmacotherapy of ejaculatory dysfunction, we have two types of pharmacotherapy. One is when there is premature ejaculation, we give inhibitory substances. When there is delayed ejaculation, we give certain other substances. So for premature, the selective serotonin reuptake inhibitors like dapagliflozin, tramadol, they are given, and other things like topical anesthetics, GABA, psilocybin, alfuzosin, they are given. Whereas for delayed ejaculation, serotonin antagonists like cyproheptadine, sometimes dopamine receptor agonists like amantadine, apomorphine, cabergoline, they are also given. Sometimes also noradrenaline also given for delayed ejaculation. But these are practically not given. Mainly you can give cabergoline if it is required, or cyproheptadine, they are clinical use. So there may be delayed ejaculation, there may be premature ejaculation. Then last but not the least comes female sexual dysfunction in diabetic patients. Many times diabetic patients hide sexual sex, the sexual dysfunction. Females, they hide it at most. Female sexual dysfunction has been associated with type 1 as well as type 2 diabetes. Sexual disorders reported in women with diabetes include reduction or loss of sexual interest or desire, arousal or lubrication, difficulties, dyspareunia, loss of ability to reach the orgasm. Female sexual dysfunction has been described in diabetic women since early 1980s. The global prevalence of sexual dysfunction in women with diabetes is 20 to 80%. A systematic review published in 2016 by McCool et al. Estimated that the global prevalence of FSD and among female is 40.9%. The pathological mechanisms causing sexual dysfunction in women are reduced hydration of the mucosa due to hyperglycemia. There may be poor vaginal lubrication. There may be urinary tract infection. There may be vascular complications like inadequate blood supply to the vagina and the clitoris. The neuropathy and neurological disorder may be associated. They may cause structural and functional changes in the genitalia, reduce the sensitivity. Stroke, epilepsy, traumatic brain injury may be associated with this female sexual dysfunction. Hormonal imbalance in the form of low estrogen levels, estrogen deficiency, androgen deficiency, they may be associated with also female sexual dysfunction. Psychological trauma in the form of anxiety, stress, low esteem issues, and fear of rejection, sexual performance anxiety or trauma to the sexual experience of the past may lead to sexual dysfunction in the female, and depression, that is a very important thing that may be associated with female sexual dysfunction. Socio-cultural, like limited social relations, financial difficulties, employments, family bereavement, all these things may lead to that. The sexual dysfunction overlay of pathogenesis in the females with diabetes, the organic factors like neurological, cardiovascular, hormonal, or other chronic disorders, psychological factors like depression, stress, alcohol abuse might be associated. Sexual dysfunction in females with diabetes may be associated with interpersonal difficulties like loss of partner, quality relations, performance of the partner, socio-cultural factors that we have already discussed. The symptoms and signs of female sexual dysfunction are hypoactive sexual desire, decrease or loss of sex desire, inadequate vaginal lubrication, inability to relax the vaginal muscle known as vaginismus, pain during intercourse, non-coital sexual pain disorders. Treatment of female sexual disorders with diabetes patients. Reduce the vaginal lubrication by education, by water-based vaginal lubricants, hormone replacement therapy, arousal enhancement strategies. Genital infection should be treated and genital hygiene should be maintained. Dyspareunia, investigation of the cause and treatment of the underlying condition, lubricant use, reduce the focus on penetrative sex. Then anorgasmia, penetrative or non-penetrative vibrating sex aids, clitoral therapy device, psychosexual support, reduced libido, review and treat the any concurrent depressive illness, psychological support, administration of dihydroepiandrosterone DHEA, estrogen therapy, androgen replacement, then serotonin receptor agonist may be given. Even PDE5 inhibitors may be helpful in certain situations. That is there. Summary of the available therapies for female sexual dysfunction. First is modification of the risk factors, control, healthy diet, exercise, assessing the psychosocial issues, cognitive behavior psychotherapy for desire disorders and vaginismus, clitoral therapy, treatment of the associated diseases, hormonal replacement therapy. Then coming to the conclusion of the topic, that which this conclusion includes the erectile dysfunction, ejaculatory dysfunction, and female sexual dysfunction. Diabetes is an increasingly prevalent problem that has been associated very strongly with the sexual problems both in men and women. Diabetes has numerous end-organ effects and also exerts a substantial psychological toll, which may predispose the diabetic people to sexual problems. Erectile dysfunction is common in men with diabetes. These men tend to present with more severe and refractory erectile dysfunction compared to non-diabetic peers. Women with diabetic may have also sexual dysfunction. The sexual health is a very important aspect of diabetic care. Important lifestyle changes, close management of diabetes has been associated with the improvement of sexual function. Then take-home message. Erectile dysfunction is an important but often neglected complication of diabetes. Physicians should include taking a history of sexual health. Early diagnosis and prompt treatment of ED can be very rewarding to both the patient and physician. Besides ED, males may have ejaculatory dysfunction and a lack of desire, which may lead to sexual dissatisfaction and infertility. Sexual dysfunction also occur in female and must be addressed. In addition to the therapy specifically tailored to sexual concerns, management of underlying diabetic condition may markedly improve sexual quality of life in people with diabetes. Thank you for your kind attention.
Thank you, sir, for the very informative session. We'll move on to what our audience have sent us questions, sir. And sir, our audience has sent a lot of good feedbacks Lot of positive comments, sir. So I want to convey that to you as well. And can we move on to the first question, sir, for the question and answer session?
Yes.
Yes, sir. Okay, sir. Our first question is by Dr. L. Ramani from Tamil Nadu. So the question is, after morning dose of 20 mg tadalafil in the evening, this patient who also has type 2 diabetes mellitus does not produce any erection. What could be the reason?
The medicine was given in the morning.
Yes, sir. Tadalafil.
So tadalafil should not be given so early in the morning. It should be given in the evening hours. If it will be given at least 1 hour or 2 hours before the going to the bed and having intercourse, then in that case it will be helpful. Because it has been given so early, the action may not be. It should be given so the onset of action will be better. Even if there is a sustained action, the action will not be maintained till the after 24 hours.
Okay, sir. Thank you, sir. The next question was how do we manage such patients? So you also answered that part, that the medicine should be given prior planning. So thank you for answering the second question also. Our third question is, why do some people with diabetes mellitus complain of erectile dysfunction and some don't? Basically, this is the pathophysiology which we already discussed in the session slide. So can you go through 2 to 3 important points in pathophysiology in such patients?
We have already vividly discussed the pathophysiology,
Yeah.
dysfunction in diabetes. So if you see the vasculopathy, there may be neuropathy, there may be psychological disorders, there may be associated endocrine disorders. If any of these are there, mainly we see neuropathy and vasculopathy, they are the most important determinants in the development of AD in patients of diabetes.
Okay, sir. Thank you, sir. So we finished with Dr. L. Ramani's questions. Now we'll move on to the other questions by Dr. Niranjan Agarwal from Odisha. The first question is, does the quality of testosterone in aging male as well as patients with diabetes decrease? Does the level of testosterone and the quality decrease?
Actually, I have not discussed that point, but in patients having AD, you always do the testosterone level also. If the testosterone level, either total testosterone or the free testosterone is low, then they can be supplemented. But the testosterone supplementation is not very important from the point of view ED, but it may help to some extent. In my experience, we have given testosterone, but I don't find, unless you treat the other ways, phosphodiesterase, the psychosocial factors, only treatment with the testosterone will not help.
But does this decrease with age? Does testosterone decrease with age?
Yes, because the secretion decreases because of the senescence of the testosterone secreting cells in the testis.
Okay, sir. So the next question to this by same Dr. Niranjan Agarwal is, what could lead to decreased libido in spite of normal testosterone values?
I've already told that the testosterone value is normal, but the decreased libido may be due to other psychosocial factors.
Yes, sir. Thank you, sir. We'll move on to our second last question. This is by Dr. Ajit from Chandrapur, Maharashtra. Sildenafil and tadalafil, do they have any synergistic action? That's part 1. And part 2 is, can it be given alternatively?
Type of studies I have not come across. I think 2 5-diesterase inhibitors should not be given because they are also having some adverse effects like patients with angina, all these things. 2 drugs should not be given. At least either you give sildenafil. Suppose you are not getting good response, you can give tadalafil, but don't give the 2 drugs.
Right, sir. But can we alternate it? The second question is, can we alternate it?
No, that type of study I do not know. You either completely stop and give another drug. This one day, that one other day, that should not be given.
Yes. Okay, sir. So we answered the third part. If there's any limitation, so we answered that part as well. The last question, sir, for today: does opium give prolonged erection?
I cannot hear the question. Please
Does
repeat.
opium give
Opium
prolonged?
is a sedative drug. I have seen that certain sedative drugs, it doesn't help erection. It will rather suppress erection. That is a sedative drug. Most of the sedative drugs, central nervous system depressants, they will have adverse effect on the erection.
Thank you, sir. That's very well answered. Thank you for answering all our viewers' questions. It was indeed a privilege to hear the session from you and to get your, to learn from you, even through the Q&A answering questions. Thank you so much for today's CME, sir. We look soon forward to meet you as well. Thank you very much, sir.
Thank you, Aishwarya. Thank you, Jaidas.
Thank you, sir.